Welcome to the breakout session 2.1, option 1. It addresses recent findings for the CHW Community Health Worker Workforce Development Project of 2019 through 2020. I'm going to introduce one of the panelists, Kathy Karsting, and then she will introduce the other 3 panelists. So Kathy acts as program manager within the Division of Public Health at DHHS in the Title V Maternal and Child Health program. I did want to mention before Kathy gets started, the chat box is available to you. We have everyone on mute. So could you please put your inquiries, comments, or anything you would like to discuss in the chat box, which we'll address at the end of the panelists' discussion. And I think that's all the ground rules and directives I have to cover. So I'll turn it over to Kathy. Thank you.
Thank you, Diane, and welcome everyone to this session on our Community Health Worker Workforce Development Project. It's a pleasure to be here with you this afternoon and with our panelists. And we hope in our session today, we will thoroughly engage and intrigue you in our work, the work in the context of community health workers in COVID, and the work that's ahead for us yet with and for and among community health workers in the population and for health equity. So welcome to this session. And as we get started, I just want to share a reflection that at about this time last year, we were preparing to have this discussion with you and looking forward to releasing our findings. And it was about this time, of course, that COVID occurred and caused such disruption in our lives and in the social fabric as we know it. We want to acknowledge as a panel and as colleagues that there has been such great loss and suffering, and that will continue. And we want to thank all of you, and particularly in this session, thank community health workers for the ways that they have stepped up and served and been part of COVID response and in helping families get by. We, if anything, feel that the past year's experiences have, if anything, really reinforced the potential and the value of community health workers as respected and integral members of our healthcare and community teams. So with that, we'd like to share our work. The reports that we'll be sharing with you and discussing are the results of 3 original work streams sponsored by Nebraska's Title V Maternal and Child Health Block Grant. In the block grant, we place a focus on population health priorities of mothers, children, youth, and families, and also on equity. Community health workers and workforce development are very much aligned with the values and the priorities of the MCH block grant, and we have worked with many colleagues, stakeholders, and allies over the years, including the authors and myself, who have been working to advance community health workers in the healthcare workforce in Nebraska. In Nebraska, community health workers are a dynamic and very busy and innovative workforce that is supported and intertwined with a broad swath of diverse stakeholders and partners and allies. In producing these work products, we sought to contribute useful and actionable data and collaborative perspectives to this dynamic environment in order to engage stakeholders and meet and move the collective work forward around community health workers. Each report that we'll be talking about is original and insightful on its own. There's a work stream around looking at sustainability and funding strategies for community health workers. There's a work stream around training and looking at the training landscape for community health workers in Nebraska and looking at that with some analysis against a backdrop of how forces become recognized and integral in a state. And thirdly, a work stream involving lifting up the voices of community health workers through some extremely engaging and inclusive work led by Dr. Toure. In today's panel, we want to interest you in these individual work streams, introduce you to the authors, raise some of the highlights, if you will, from these reports. But we also will spend our time talking around some unifying themes and ask each author to speak to some of these themes that have resonated particularly through all of this work, and point to work that we can act on in the future. With the assistance of our tech partners, we'll be offering 4 poll questions to our audience. They'll appear with time for you to respond. You'll see the response, but we're not really expecting to pause our flow of discussion to discuss the polls or introduce them. So we just want you to know they're coming. We also hope that you will freely interact with the chat box and the Q&A portion to really make your comments, share your comments, and raise your questions. We hope to finish in time to address your questions and invite you into our discussion. Engagement is our goal. Well, with that, let's get started. And again, thank you, panelists, for not only your outstanding work, but taking the time today to come and discuss your work in a conversational style that we hope will really interest our audience around the themes of your findings. So let's begin. And please, in this round of talking with our audience, introduce yourself. Tell us who you are and name the published product that you have completed, and then answer one particular question about your work that we always want to know about community health worker activities. Tell us how community health workers were involved in and present in this work that you'll be telling us about. So with that, Kerry, then Terry and Drissa, please, an introduction, the published product, and how were CHW involved in your work? Thanks, Kerry. Go ahead.
So good afternoon, everybody. My name is Kerry Kernen. I'm the Division Chief of Community Health, Nutrition, and Clinical Services with the Douglas County Health Department here in Omaha, Nebraska. And my published document was titled Community Health Worker Finance and Sustainability Model, Recommendations to the Nebraska Department of Health and Human Services. So just a small piece of background before I respond to Kathy's question. We've had a kind of a community coalition specific to community health workers and building the capacity for that workforce here in the Douglas County. And actually we kind of expanded and broadened it to Sarpy and Cass counties to really think about and bring the partners together and figure out what it's going to take to build this workforce within our region. So as I was beginning the work with this particular focus around finance and sustainability, the community health workers that were around the table and have been around the table on that community advisory and coalition level were involved with this work. So they came from the health department, they came from FQHCs, One World and Charles Drew, they came from several health systems, and then we did have participation from the Public Health Association of Nebraska with the Community Health Worker Work Group. So they were involved in the meetings, within the feedback, and with developing the final recommendations for this report.
Terrific. Thanks, Kerry. And thanks for giving us that context of the very inclusive work you've been doing with community health workers in the greater Douglas County area. Thank you. Terry, go ahead.
Good afternoon. I'm Teresa Hultquist. I am an associate professor at the University of Nebraska Medical Center College of Nursing. I am certified as a public community health nurse and actually grew up in rural Butler County. So spent all of my years through high school on a farm. And so kind of have straddled rural and urban for many years. And the title of my work was Nebraska Community Health Worker Training and Curricula Assessment, Rubric Development and Testing. And that is a mouthful. But basically looking at all the training and curricula around community health workers in the state. And I had 19 key informants that helped me to understand the role and the training and the curricula, 4 of whom were community health workers that were actively working in some role in community health. And they helped, as I interviewed them, in helping me to understand their current roles, how they saw the training and curriculum that they went through, or if they were involved in a training program or just trained on the job. They talked about their work with the community and individuals, and they also talked about transferability of skills. So that ability to, if the project that they were working on might end, how could they transfer those skills to another type of work that would be a community health worker role?
Terrific. Thanks, Terry. Yes, that sense that we get to the community health worker, speaking to the fact that they have a skill set, they're a professional, and that moving between job locations is an interesting quality to see. Thank you. Drissa, please tell us about the big undertaking you had with community health workers.
Thank you, Kathy, and hello, everybody. And thank you for the opportunity to be part of this panel. I believe we should have more people in this panel than any other panel because of the importance of this work we are doing. Thank you, Kerry, and thank you, Barry, for being here with me. To introduce myself, I'm a trained physician and a public health professional by passion. I work with the George Washington University before moving to Nebraska, where I spent 11 years with the Center for Reducing Health Disparities. And recently I moved with the MMI, Education and Child Development Department, as a faculty member. The work we have done is centered on strengthening the community health worker workforce to improve maternal and child health in Nebraska, a statewide assessment of need, barrier, and assets. It was a great and a rewarding work we have done. We engage and we have a 10 focus group with 65 community health workers. And we did a survey with 121 answers. And also we have a key stakeholder interview. All these steps before even the questionnaire, we meet with the community health worker, the community health workers, the steering community to have their input and have the comments from them. And for the survey, even we did a pilot testing working with the communities there, took the survey and get back to us with the answer and make sure the question we are asking is relevant to the work they are doing. That's how we engage them. And thank you for having me here in this panel to discuss the finding of our work.
Well, super panelists, thanks so much for saying so much so quickly and really giving us insight to, it's just really insightful work in all respects. So let's go on with our discussion. Clearly, I'm sure our audience can see in the chat, you should be able to see the link to go to the web page where you can see all of these reports in their full form as well as highlight sheets that accompany each one. And these are very, they're original and scholarly reports, but they also, as I say, contain just some great insights about and sharing the authentic voice of community health workers. So in our next question, Drissa, maybe you'll start us off. Talk about your work from the standpoint of finding that really is empowering and validating to community health workers.
Go ahead.
Go ahead.
Thank you, Kathy. And I want to quickly share something quickly with you. This is when we did the community health worker need assessment. This is one of the words expressed by community health worker. You know, they are proud of the work they are doing. One of them say, we are there to advocate for the client, but we are not only advocate. advocating, we are trying to close the gap in communication between the client and the provider. So those are questions coming there, and they express how proud they are with their work, and they are doing a lot of variety of work, which we are going to go deep in later on, because they are the bridge between the community and the healthcare system. Thank you.
Drissa, that was a terrific way to share about some of the empowering work. I agree that the way that your team brought us the voice of community health workers in your report is really terrific. So Kerry, then Terry, how about you? Share. Yeah, I know that you're a stakeholder and an ally in this work. Tell something that you found really empowering for CHWs in the work.
So as a reminder, our work group and kind of focus area was around finance and sustainability. And as you can imagine, that arena is extremely complex and layered, and every state is doing it very differently. They're funding it differently. They're setting up the infrastructure very differently. So the challenge, I think, was to discover through the process what was going to be most impactful for the state of Nebraska, and really support the community health workers as they are engaging in this work every day for long hours. And really, I think to what Dr. Toure mentioned, really validating what they bring to the table, both on an individual level, a family and community level, and then, really that wider geographic component. So I think, at the end of our report, at the end of our process, we came up with some very strong recommendations to the state of Nebraska on what we felt was going to be the most impactful to really support the community health worker. And it was through a lot of conversations, it was through assessment, it was through an analysis, because we were very firm in our commitment that we didn't want this to be grant funded, because we recognized that grant funding ebbs and flows. We really wanted something that was going to be long-term sustainable and really support this workforce as they're doing, such an important job on a day in, day out basis.
Super. I agree. The message about the value of the community health worker comes through so strongly to really provide a foundation for that sustainability work. Terry, how about you? Go ahead.
And I, as you think about the scope of the work that I did, it was around training and curricula. And so as I looked at the training and curricula that was available to review, most of the training and curricula did use some kind of framework for their training or their competency assessments. So that validates that the community health workers are getting much of the information they would need in order to be skilled and competent in their work. And the second item would be that the organizations who hired community health workers that were key informants talked about the value of the community health workers to their work. And they talked about the value of the community health workers being part of the community, that they sought folks who were like the community so that the value was there for the community members to see them as a partner. They talked about that the community health workers were part of a team, although they did mention that developing that team takes some time and some sorting out of whose roles, what kind of things we're going to do. But they also talked about the needs of the clients. And when we think about some of the conversations today in the various sessions, thinking about creating opportunities to overcome barriers or opportunities to address social and health needs was an important component that organizations talked about in using a community health worker.
Great. Great. Thank you. Thank you. Just great to draw out just the many positive messages and insights there are that I think can really contribute just to our shared dialogue about community health workers. So thank you all. Well, let's move on to another concrete topic about community health workers. We entered into this work, as we know, in an environment where there has been some work in the community health worker workforce that preceded us, and always wanted to honor that. Some work in 2014 from the Public Health Association of Nebraska, many advocates and stakeholders who have been working on training. So we have been aware that there has been some previous consensus work around competencies. The American Public Health Association recommends or has a well-accepted framework for competencies. Douglas County Health Department, under Kerry's leadership in that work group, they tackled the topic of competencies in their work and aligned strongly with this foundation. So now our subject is competencies and the competency framework that we have for community health workers here in the state. There are some, as I have alluded, some fairly, I would say, well and widely adopted competencies for community health workers from the Public Health Association of Nebraska, but that's back from 2014. So to our authors, I know that there's a thread in each of your areas of work having to do with the competencies and the role of the community health worker. Who is a community health worker? What do they do? Is that something that's understood or still unknown to many people? So at this round, starting with Terry, please. Describe how you approach the topic of community health worker competencies, a role description in your work, and what are your findings about this subject of community health worker competencies? Go ahead.
Thanks, Kathy. I use the American Public Health Association and the FAN competencies, so those 10 areas, which include communication skills, interprofessional skills, capacity building, teaching skills, advocacy skills, organizational skills, service coordination, outreach methods and strategies, client assessment and community assessment. And I used a large or a wide definition of the role of community health worker because there are a variety of aspects and jobs that they could be working in. So I looked at that the community health workers were building individual or community capacity by providing outreach, by serving as a trusted liaison, by advocating and supporting individuals and communities, facilitating access to a variety of services, partnering perhaps with researchers on research studies or getting information about interventions that are evidence-based to try for clients and communities. And these actions, these competencies really help promote a trusting environment in order for individuals and communities to engage in changing their knowledge base, to increase their self-efficacy or sufficiency in managing and improving their health, to look at preventive activities, wellness activities, and then of course, chronic disease management. And the community health workers, as was mentioned previously, the community health workers can help remove barriers to care or to knowledge, but they also help to promote removing those barriers totally and figuring out ways that we might not have to have those barriers in the future for other individuals in the community. And for findings, as training and curricula, I looked at how did the community health worker training and curricula help them develop skills and competencies through classroom and practical experiences? So some of my findings were that some programs, but not all, provided interactive or participatory activities in the classroom. They might have provided opportunities to apply the content either in the classroom or online, because some programs are online. It could be journaling, it could be classroom discussions or online discussions, could be role playing, presentations, quizzes, tests, those kinds of things. And not all programs provided hands-on participatory experiences, but those who did things like an environmental scan or environmental assessment, a home visit with documentation, a capstone project related to a specific content area, or participating in a forum with current folks who are being served and understanding better their health needs and the needs from other services that they might provide as a community health worker. The training programs did have some content on cultural humility or cultural competence or cultural diversity, but not all training programs really use the class standards, the culturally and linguistically appropriate services. And so that would be an area for us to look at down the road. And similarly, some provided information about health equity or understanding the health literacy level of a particular client or group, but not all training programs included that information. And some provided information about documentation, but not all did, because if they were a more general training program, they might not have had the specific information. They left that to whoever would be hiring the community health worker. So things like the standards they might use to document. That also left sometimes the community health workers' work seen as output, like number of visits, number of referrals, rather than outcomes, which could be things like what kinds of health needs are met, and did folks improve their health, their perception of their health status, using services. So looking at the outputs versus outcomes was another finding. And then the final one was that some used community health workers in the training, or especially job shadowing, but not all did. And having someone who is in the same role as I in that training would be really helpful for the community health workers to see someone in that role and how they manage the client and community interactions would be really helpful down the road.
Thank you, Terry. Just a super place for us to start on this question of competency and roles. And for those in our audience, just to say it may have sounded somewhat detailed, so do just go to the report and check it out. But I hope that what has come through for you as well with Terry's comments is just that thoughtful approach to looking at the fact that we know, many of us know, that in Nebraska, community health workers are trained and brought into service in many different ways by many different employers and programs. And it was so helpful for me to become acquainted with Terry's work and see a way of looking at that diversity and training approaches, even embracing it. We know we're not a one-size-fits-all state, but also being able to see sort of lines of assessment of training that really bring out the competencies, the role, the practice, the active engagement. It was really helpful for me to understand, just to see Terry's analysis, and I'm sure you heard that in her remarks. I am just going to give a quick shout out for one of my favorite findings in Terry's discussion about documentation, is that in her report, she gives us some insight that community health worker documentation is really important, and we can look at that as the way community health workers tell their story. And perhaps we should be aware, as our workforce develops, that an electronic health record may or may not really capture the uniqueness of the encounters and the services that community health workers carry out. So just some tidbits there to get us thinking about what does the community health worker story and form of documentation look like when it's truly owned by community health workers. I thought that was a neat part of your work. Well, let's go on with this question. Drissa, you, of course, had a very different approach to your work. And won't you share with us a little bit about how you addressed what you found about competencies and role of the community health worker through your work?
Thank you, Kati. You know, I truly agree with you and Terry about how they get to train in different way. And when we approach this question during our focus group, we ask a question, how were you trained? What did you learn later that we used to have known before starting the work? And with a follow-up question, how was your training and how are you being trained, who trained you? We have all these questions and they come up with different answers, and many of them get training through the job. Some people have a certification, they have a course where they went and attend to have their competency before. And for the role, when we ask the question during our survey, we have a community health workers, they play different roles, you know. And looking at this one, I'm sharing with you, some of them, most of them are calling themselves promoters, and some community health worker, they have a different roles they are playing. And when we ask the specific question about what area of work they are doing, this is the answer they come up with. You know, they work with different area, with different topic, HIV, behavioral, mental health, and reproductive health, all that they are doing with the community, with the family, and we try down again to go more deeply to maternal and child health service providers, since our report was about to empower them and to improve maternal and child health services. This is what they qualify themselves as being doing: home visiting, prenatal counseling, and with access to mental health care services. You know, they have a different area of work, they have a different title, and they have a different role, and they have been trained differently, you know, through specific training, through work. And when we go to certification, we will see some other questions raised about training, how they get training. Thank you.
Super. Thanks, Drissa, for sharing your results. Now, Kerry, you had an even different, but very specific and purposeful way of dealing with competencies and roles in your work. So won't you go ahead, please?
Thank you. So to absolutely mirror what Drissa and Dr. Toure said, we you know, we're all on the same page as far as the titles and the breadth and depth of what community health workers do. So I think that was one, both acknowledgement and challenge as this work group started to think about recommendations to the Nebraska Department of Health and Human Services. And they had a lot of interest and felt there was a lot of potential around exploring the utilization of the process to think about a state plan amendment through the Medicaid program here in the state of Nebraska. So through some very rich conversations with both the state Medicaid director and then those connected with the Behavioral Health Division, which has actually gone through this process for a state plan amendment for a title position called peer support specialist or peer counselors. We really got some great feedback, and competencies were embedded throughout. So unless and until we really think about those competencies, what those are, the opportunities to, as much as possible, come to some level of kind of consistency across the state of Nebraska, recognizing that we really think we need to think about kind of a niche in what the service delivery realm looks like for community health workers. And I think that's going to be a wonderful challenge because, again, community health workers fall into so many roles. They, you know, can be embedded in health systems, FQHCs. I call our breastfeeding peer counselors as part of a WIC program a community health worker. They're just very much focused on maternal child health around breastfeeding and nutrition support. So I think that's going to be one of the, I think a great challenge is to really explore and look at what that service delivery is. And then once that service definition is really developed and then adopted across the state, connect that service definition to what those core competencies are. And so I think for all the community health workers, you know, from this report, it will be, here's the foundational components, but then what are those additional core competencies that may be unique and specific to the role and responsibilities that that community health worker has. So I think, and we haven't quite got to this yet, but once we really can identify those and get those kind of adopted and formalized and consistent throughout the state, then that I think, not that it's easy, but I think clarifies the next steps around training and certification. And those are all the things that we're going to need if we think about the finance sustainability piece, because at the end of the day, the finance and sustainability support will come in how we're measuring the health impacts to the communities that we're serving. So I guess one of the things I can speak to personally throughout this process is that for the longest time, I just felt like it was just this big gray cloud because there was just so much to think about. There were so many pieces and parts, and I couldn't quite visualize. I'm a visual person. I couldn't quite figure out how they were interconnected. And I think after having these conversations and working within this work group, it just now seems very streamlined. It's methodical. It's step by step. So I think, as we think about the core competencies, they will be foundational to really building this capacity for this workforce in the state of Nebraska.
Thank you, Kerry. Super comments, and I think we can really appreciate the clarity, just as you've shared you've experienced, but also that you bring to these discussions. I agree too that even in your summary, the idea of we understand that there are many titles and perhaps the role looks different, but we need to move to a service definition. And that core set of competencies does have a purpose, but it's not meant to be limiting. I think so many people see that, yes, the role appears in so many places, takes so many forms, saying that there's a shared and consistent set of core competencies, I don't think has been meant by anyone to be limiting, but more to share, just as you say, a foundation. Well, Kerry, that just as the word came to you as well in your comments, brings us to this next feature of certification. And in all respects, our authors addressed questions of certification, considered certification. So Kerry, why don't you just go ahead and tell us about a little bit more about how certification looked as you developed your work and came to your recommendations.
Thanks, Kathy. So before I share how we thought about this through our work group process and the final report, on the Douglas County Community Health Worker Coalition side, this was a hot topic for several weeks. And I think this has also been a challenge for states, even through the American Public Health Association. This has been a lot of thought, a lot of discussion, pros and cons, logistical considerations. And so we went back and forth between, when you use the term certification, what does that really mean? Had some discussions around licensure, and we quickly moved away from that because we felt that was just not really a good fit and quite limiting. But I think at the end of the day, as we had these conversations around competencies and training, is two things that kind of bubbled up, and I think this goes to this certification component, is that within the kind of building this infrastructure for this workforce, we will need to consider what does the accountability for the community health worker workforce look like. So kind of what is that supervisory component? And then what is that certification process? And in my report, I've got italicized around certification because we weren't quite sure what that was going to look like, but we felt very strongly as a work group that again needs to be consistent across the state of Nebraska, especially if you think about, these individuals, if they're moving from, employer to employer or county to county, so that consistency is there. So once that certification is provided based on core competencies and training, they can then show that to potential employers to say, here's the foundation of knowledge that I have built based on my experience, my workforce experience, that they really can bring forth as identifying the expertise that they now have within this field of work. So, I don't know that the focus of this report was not really digging too deeply into certification, but recognizing that it will be a vital component as we think about the funding and sustainability component.
Very good. Thank you. Terry, go next. Do you have some thoughts about how this topic of certification figures into your work?
Thanks. As you think about as Kerry talked about, not only the supervisory aspect of what kinds of roles the community health workers are working in, and then how do we make sure that we're meeting the needs of the population we're serving, it's also that foundational knowledge and then the specialized knowledge. So understanding certification from a point of saying entry to practice, for example, in thinking about what are those foundational skills that we would want every community health worker to know and to be able to have those skills. Because as an organization, it makes it more difficult for an organization to hire a community health worker who might have done a very specific task in a previous agency, but not necessarily is not the task they're looking for in their agency. So understanding that foundational component and how we could build that skill set so that community health workers could talk about what skill sets they have, and organizations would know here are the things that the role comes with, and then here are the additional things we want to train for the specific tasks we're doing. One of the things that I found was there were a couple of areas that the competencies, FAN and APHA competencies, weren't well discussed in the training programs. One was related to leadership. And from that is really thinking about capacity building. How does the community health worker perform in a leadership role in making sure that the capacity is built, whether it's in an individual or a community? The second thing was thinking about teaching skills. So many community health workers might work with an individual, helping them to learn breastfeeding basics that families could use, but also training perhaps a community group or talking to a funder organization about how this community health worker work is supporting the community. So that capacity building, that teaching are important skills for them to have. And then the final was advocacy. And that related to thinking about budgets and financing, not necessarily that I'm understanding or that I'm knowing that this particular thing can be paid from Medicaid or Medicare or other services, but more in thinking about what are the resources we have for this group of services we're offering. How does a community health worker fit in those resources? And so thinking about those as competencies. And I like what Kerry said about in thinking about if community health workers have a clear understanding of what their scope and skills and role is, that helps organizations to be able to say, gosh, we can transfer these skills that you have into these new areas that we need and provide competent, good services to our clients. So that certification, that foundational level would help us to be able to do that better. I also think that one of the things some of the key informants talked about was how are they different than nurses or social workers or public health workers? So how does this role fit with and is different from the other roles? And so that certification, those foundational skills would help to kind of clarify that there's a lot of overlap, but there are specific areas where each of those specialties can work well with clients and communities.
Wonderful points to bring to our discussion. I think oftentimes when I've been present for conversations about certification in the past, we've kind of tumbled into sort of a regulatory mindset, something that has to be done or protected. And really, I find so much now that our conversations about certification are really uplifting and positive. They're reinforcing to what the workforce has to offer. For me, it's helped open up ideas that certification systems don't necessarily need to be government regulated, and still there are many ways to just that bring consistency and lift up a profession. So just great insights coming. And Drissa, I know that in your work as well, you addressed how community health workers are feeling or how they respond to this question of certification. So thanks for once again bringing us some community health worker voice from your work.
Thank you, Kathy, for this question. You know, this we explore this question through focus groups, survey, and interview with the key informers. There were different voices, but the specific question we asked for the survey was, do you think Nebraska should have a statewide certification program for community health worker as some other states? And we decided and say yes or no question only, to be more specific, to have their insight. And also we have an open-ended question asking them, why should or should not have. And surprisingly, we have an answer. 80%, 81% were in favor of certification, and only 19 or 20% was opposite. And they have their own point also. And during one of the person who said no, opposing certification, brought out some point. She said, I feel that skill necessary to do community health worker are typically learned at the job and from experience out working with family in the community. So it was so powerful. And we have a couple of quotes like that. They express why and why should not. It was really during our focus group also, there were a different opinion, regarding certification, but most of them were in favor of certification. And when we dig in with certification with stakeholders, proponents state that certification will create individual pride. That's from the stakeholder viewpoint, and also core competence and validate the work community health workers are doing. And some were saying opponents list barriers such as lack of infrastructure in Nebraska, cost, time, and literacy level as some factor. They have a variety of things explaining the way they think certification should be there or not. This is our finding.
Thank you so much, Drissa. Yes, seeing the barriers in that group that was not in support or had those comments about certification really offers us some particularly important insight about what community health workers might see themselves as consideration. And certainly knowing, as we do, that the community health worker workforce is diverse. The literacy level, the language levels, and so forth are things that we value about community health workers, not things that we want to create as barriers. Well, panelists, you're just being great with my regimented instructions to you as to time and so forth. So many, many thanks. You've been sharing lots of insights and data from your work. Again, audience, please do see the entirety of these wonderful original and scholarly reports, as well as our highlights available at our DHHS CHW webpage. So going on, let's turn to action steps. And I think all of you have concluded or included in your reports insights about where this work points. So let's turn future looking and begin with Drissa. If you would like, please, won't you share some thoughts about action steps? Name one or two action steps for community health worker workforce development that you think your work brings forward. Thank you.
Yeah, thank you, Kathy. We did this job. We have a lot of recommendations, but some of the recommendations, two recommendations stood to me very well, which is we think there is a need of developing model community health worker program in Omaha that can clearly demonstrate the efficacy and impact of the work of community health workers in serving diverse population and addressing health disparities. Being part of a Center for Reducing Health Disparity, we think they can play a huge role on playing that and making sure people have access in timely care. And also we believe it will be very, very important for stakeholders and community health workers in Nebraska to have a more extensive and rigorous debate, of the need establishing a state certification program for community health workers. That was the two strong findings we have, and there are more, but I will not go through all that. But there is a need for stakeholders to be engaged, working closely with the community health worker to make sure programs are there, and also there are systems for them to be able to reduce health disparity in Nebraska. Thank you.
Wonderful. Very forward looking. Keep moving. address the certification questions so important to so many, and keep gathering evidence of effectiveness with our community health worker program. Super, Drissa. Thank you. Kerry, how about you? What are the action steps you want to share? You, in some ways, were the most deliberate about them, giving us our marching orders. So go ahead.
I did. So much like Dr. Toure, our group came up with, I think, about 5 or 6 action steps, but the 2 that we felt carried the most weight as recommendations up to DHHS were, 1, that we support and encourage health systems to hire and integrate community health workers into their healthcare systems, not just specific to the health kind of hospital side, but really thinking about that within their primary care medical homes, and supporting them as far as, conducting, and I'm going to use this term, the return on investment. So I think sometimes that's a pretty broad term that can mean a whole lot of different things, but how they're seeing the impact of community health workers on their patient population that they're serving and supporting, and identifying that difference within their health outcomes. The second very strong recommendation was that Nebraska establish a statewide work group specific to developing a funding and sustainability model. And this group really wants the state, with support and cross-sector representation, to take a very deep dive into this potential of a state plan amendment to see what that will take as far as all the steps with the service definition, the connection to core competencies, accountability, certification, because it was strongly felt that if all those pieces and parts are in place, that really provides the infrastructure for, again, that funding and sustainability component. So yes, 2 very clear marching orders that we submitted to the state for consideration.
Terrific. Well done. I will be coming back to the statewide sustainability work group shortly, but I just want to call out again that return on investment point. And when you read the report, you'll see how clearly Kerry does point to that, and it just is I think such a useful and helpful action step to identify that. We started out talking about how easily the value proposition comes to us, the value of community health workers, and yet we haven't quite nailed down the formula that we want to use to really describe and measure that. And I guess I kind of took away from Kerry's style that it's one of those things where you sort of get the nudge that if you wait to find the perfect one, you'll wait forever. But the real message is adopt a return on investment formula for us to go forward with this work. So even if it needed to be refined or improved, just Kerry really pointing to that will help our communication, our numeracy, our literacy in talking across payer systems, provider systems, service systems, if we can really devise that. So it just really helpful and insightful and clearly stated. And let me see, did we get to everybody? Terry, did you name your action steps too?
I did not yet.
There we go. Thank you so much. Please, your turn.
So I also had 6 recommendations from the report, and we've talked about a couple of them already. The portable, recognizable skill set for both community health workers and for organizations. So I wanted to focus on really the training and curricula a little bit more. The training ranged actually in the programs that I looked at from 29 hours to 203 hours. So while we don't need necessarily a totally structured training program, it would be value added to look at what are the major components of the training program, both the classroom or online training, the participatory or practice training, and making sure we equip community health workers with both of those right-sized content areas so that they are really ready to be prepared in the foundational training. And then if additional training by an employer is needed for a specific skill set, that would be then added on. And then I think really the other one would be equipping the community health workers with the ability to think broadly about their output and outcomes. And we've kind of talked about that before. So what difference is the community health worker role helping the team to do? with health outcomes from populations, with policy changes that might decrease barriers for care and social services. So having the community health worker well equipped to help that team talk about what difference they're making in the community, and specifically then being able to talk about their role, so that those skills really are portable across multiple types of roles that they might be in over time.
Terrific, terrific. Thank you. Thank you again, panelists, for sharing so much interesting information so well. On behalf of the panel, I again urge you to see the work, but of course also to contact the panelists if you have questions or would like to explore the work further. Our purpose again in bringing this session to you is really engagement. It's bringing this work to community health workers, stakeholders, and allies that we think really will be our momentum going forward. So we really appreciate what you have in the chat box for us, and the inquiries and the questions you may raise, and the work that you'll be continuing to do with us and other stakeholders as we go. So at this point in time, I'm going to take just a few minutes and follow then, as we've reported out on this work that our maternal child health program invested in 2019 and in 2020, I'd like to just make a few comments about what we believe is ahead for our maternal child health investments. Again, just to emphasize, we see this workforce development as so strongly aligned with our maternal child health priorities, addressing health disparities, and working towards equity for all families and children. So I'd like to just quickly name that one of our first action steps following the release of these reports and consideration of the findings and recommendations, and addressing COVID disruption, of course, was to determine that it was really time, perhaps even past time, to not only include community health workers in this work, but to make certain that at least as we in our Title V maternal child health program went forward, to assure that it's actually community health workers who are front and center in the next steps we take. To achieve that, over time, we've built up communication networks with community health workers, their employers and trainers, and try and be faithful about communicating. But more so, we were interested in drawing on community health worker leadership and expertise to come into our program development and inform our next steps. So to that end, our program has entered into contractual relationships with 11 community health workers working across the state in many different roles and situations, who are working with us in that capacity as consultants and trainers to inform future work and to help us see our work and develop our work through and with and for the perspective and well-being and advancement of community health workers. We also are prepared to act on the recommendation that you've heard Kerry Kernen describe, coming from the Sustainability and Financing Work Group, that this work cannot be accomplished in 6 months, but perhaps it could indeed be accomplished in Nebraska over a period of, well, perhaps let's say 2 years. To that end, the maternal child health program is prepared to make investment in the form, I think it would look like a subaward to an entity who would agree to facilitate and coordinate this work involving many stakeholders, including community health workers, in order to sustain and support an interactive participatory statewide work group who can continue to assess the action steps and recommendations that Kerry and our other authors have put forward in their report, and determine how, in addition, Title V can help develop the community health worker workforce. We're also setting aside some resources to work with these 11 community health worker consultant trainers to actually involve them in a training project with some technical support from UNL at the Center for Children, Families, and the Law, where we expect to help contribute to the availability of community health worker training in Nebraska, along with other partners, particularly focusing on some of our maternal and child health priorities, including mental health of families and children in the population. Lastly, in Dr. Toure's work, the workforce assessment project that Dr. Toure and his team completed at the Center for Reducing Health Disparities at the University of Nebraska Medical Center and the Center for Reducing Health Disparities yielded so much rich and insightful data that, in addition to the report, which you will find on our website and we've been discussing, the Center for Reducing Health Disparities is this year engaged in an additional data analysis about their findings. So we look forward to seeing that work. Well, here we are, 2 o'clock. Again, thank you, panelists, for all that you have shared and brought forward.